Welcome to Falcon Physician Reviews for Pathology for USMLE Step 1. We continue with our lecture on bone pathology, in this section focusing on trauma and infection and bone-forming tumors. When one thinks of trauma and infection of the bone, one of the first topics that should come to mind is osteonecrosis, which simply is an ischemic infarction of the bone. The issue here for you to decide both on a test question and clinically is what it is that has caused the ischemia. The causes are numerous and varied and include etiologies such as fracture, the use of corticosteroids, thrombosis or vasculitis, anything that impinges upon the blood supply to the bone, and then radiation injury. The pathology in the medullary cavity will show necrosis of the cancellous bone and the surrounding marrow, but the thing to note is that the cortex will generally not be affected. Subchondral lesions will show wedge-shaped areas of necrosis with viable overlying articular cartilage. Clinically, the main thing is that these patients are going to present with chronic pain. Fractures can be broken down into a series of subtypes, including traumatic fractures, as one might expect seeing, say, a patient from a car accident, stress fractures that one might see in athletes, which develops after repetitive mechanical stress to a particular bone, then pathologic fractures due to some sort of secondary etiology, usually metastatic disease. Osteomyelitis refers to conditions where there is inflammation of the bone and marrow due to some sort of infection. This can be due to pyogenic causes, usually bacterial, tuberculosis infections, and syphilitic infection is a special case with particular changes that occur to the bone that are worth knowing about. Pyogenic osteomyelitis refers to a situation where there is bacterial infection of the bone, the organisms having reached the bone by a variety of sources. The usual and most common way in which the bacteria reach the bone is via hematogenous spread. However, they can also get into the bone by direct extension from a nearby wound or by direct implantation. The organisms that are involved in the development of pyogenic osteomyelitis are numerous and varied. 90% of the time, however, if one does find an organism, it will turn out to be Staph aureus. However, one must remember that in only 50% of the cases, when one is trying to culture for the causative organism, in a case of osteomyelitis, will those cultures be successful. Again, Staphylococcus aureus will be the most common organism that's found, but there are other organisms involved. E. coli, Pseudomonas, and Klebsiella will all be seen in patients, particularly those that have genitourinary infections. If one is dealing with osteomyelitis in a newborn, think about things such as group B strep or Haemophilus influenzae. For sickle cell patients, remember the difficulty that they have in dealing with encapsulated organisms, and so think about entities such as Salmonella. And finally, IV drug users, as usual, present a slightly different class of organisms when it comes to infections, and one should think about Pseudomonas. With osteomyelitis, it is divided, as many infectious disorders are, into an acute phase where the patient presents with some of the classic features of someone with an infection, malaise, fever, and chills, a subacute and chronic phase. And obviously, the treatment is going to be to try and determine the organism and treat it with the appropriate antibiotics. Other forms of osteomyelitis include tuberculous osteomyelitis and syphilis. Tuberculous osteomyelitis are usually solitary lesions. And there is one special case when tuberculosis involves the spine. This is classically referred to as Pott's disease, the spine, knees, and hips being common sites of involvement by tuberculosis. Syphilis. And with this disorder, what one needs to concern oneself is whether you're dealing with acquired syphilis or the congenital form. In acquired syphilis, changes to the bone and osteomyelitis will be seen in the tertiary phase of the disease. Remember when we were talking about syphilis in the lectures on the male and female reproductive system, we divided it into primary, secondary, and tertiary phases. So in the tertiary phase of syphilis, what one will see often is something termed saber shin, where there is a massive periosteal bone reaction with deposition of bone on the medial and anterior surfaces of the shin. Congenital syphilis and osteomyelitis presents a slightly different picture. The lesions begin to appear in the 5th month of gestation, and the spirochetes have a couple of areas that they prefer to localize to. They prefer going to areas of endochondral ossification, creating a condition known as osteochondritis, and they also like to localize to the periosteum, a condition known, not surprisingly, as periostitis. What one sees in terms of pathology is granulation tissue with plasma cells and areas of necrotic bone. A silver stain will allow you to determine the presence or absence of the spirochete. We now move on to the topic of bone-forming tumors. The number of tumors that can form in bone are many and varied, and what one wants to consider when trying to determine what sort of bone tumor you're dealing with is remember a couple factors about clinical history and radiology. The first is what is the sex of the patient and what age group you're dealing with, because certain tumors are more common and have a predilection for certain ages and either males or females. The other thing to remember is where is the lesion occurring in the bone. And we will have a diagram coming up towards the end of this lecture that deals specifically with epiphyseal lesions, but which also delineates where lesions occur in terms of the metaphysis and diaphysis. Sometimes simply knowing where in the bone the lesion is occurring will allow you to narrow the differential diagnosis down to one or two entities. We will begin, however, with considering one of the most common tumors of bone, the osteoma. This is simply a benign tumor bone that extends from the subperiosteal or endosteal surfaces of the cortex. Generally is one that is seen in middle-aged adults. If you have a patient who presents with multiple osteomas, consider that they may be suffering from Gardner's syndrome. In terms of the pathology of these lesions, what one sees is woven and lamellar bone deposited on the cortical surface. Think of this lesion if you have something that's occurring in the patient's facial or skull bones. Unless one is dealing with a case of something like Gardner's syndrome, these are usually solitary lesions, as their benign nature may make you realize they will be slow growing, and the predominant way in which they produce an effect on the patient, given where they're localized in the skull and face, is they may impinge upon the sinus cavity or push into the brain. Now, osteoid osteoma and osteoblastoma are two other common benign bone tumors which are noted to have very different responses in terms of how they respond to therapy and how they react in the patient. Both are benign bone-forming tumors, but they appear in different groups in different places. The osteoid osteoma in general is in younger patients, those under the age of 25, and has a predilection for the male sex. It appears in the cortex of appendicular bones, so think of this in bones of the femur and tibia. There is often extensive pain for the patients that is worse at night, and what the patient will report is that the pain is relieved by the use of aspirin. And when you get this clinical history, you want to think about an osteoid osteoma. The osteoblastoma, on the other hand, has a predilection for the spine, in particular the vertebrae. The pain is dull and achy and is not relieved by aspirin, and thus is not thought to be due to excess prostaglandin E2. The pathology for these tumors, for both of them, they will appear as well circumscribed lesions. If one looks at them microscopically, what we will see is random interweaving trabeculi of woven bone. Radiographically, they appear as small mineralized lucencies. You can appreciate both the radiographic findings and the histologic findings in this slide. The H&E shows the interweaving trabeculi of woven bone surrounded by rims of osteoblasts, and then the radiographic picture simply shows a small lucency surrounded by a rim of new bone. In terms of malignant tumors of bone, the major player that you're going to want to concern yourself with, both for the exam and clinically, is osteosarcoma. It is the most common primary malignant tumor of bone. It is interesting in that it has a bimodal age distribution. So it has a predilection first for appearing in patients under age 20, and approximately 75% of your cases will appear here. It also has a predilection for the elderly, and if one sees osteosarcoma in an elderly individual, you want to think whether they have some underlying condition that predisposes them to the development of osteosarcoma. Remember from earlier in this lecture, we talked about osteosarcoma appearing in approximately 1% of Paget's disease cases. It can also appear following infarcts and prior radiation. It also, as a tumor, has a predilection for the male sex. When you're dealing with the 75% of the cases that arrive in younger patients, look for it arising near the metaphysis of long bones, especially in the tibia and femur near the knee. In the elderly, there appears to be an approximately equal incidence in the flat and long bones. In terms of the pathogenesis of osteosarcoma, the genetic events leading to the development of this tumor are not completely understood. It is known that osteosarcoma will tend to present in patients who have had hereditary retinoblastoma. This development of the bone tumor may be due to the effects of the treatment for the retinoblastoma, which often includes doses of radiation, or it may also reflect the hereditary genetic changes that are present in the patient that predispose them to the development of the retinoblastoma. It is also recognized that abnormalities in genes that regulate cell cycling are involved in the development of osteosarcoma, and this may be due to the fact that they are expressed in sites that regulate